most of our allergen diagnostics have been developed in the West. And because they've been developed in the West, are they fit for purpose for African populations or not? And this comes back to what we're saying, that when it comes to diagnostics or anything, we need context-relevant diagnostics. And this was based on...
What comes to your mind when you think about the immune system? Now think about Africa. What does it bring to mind? On ImmunoAfrica, we invite professors, postdocs, PhD students, and everyone in between to tell us about their journey into immunology, the questions driving their current work, and the impact they hope to make on the continent. I am Wealth Okete, your guide on this adventure, or better yet, your co-explorer. In each episode, I bring you the inspiring stories, innovative approaches, and invaluable perspectives of the Africans advancing the field of immunology both locally and globally. Join me for an exciting adventure into immunology through the hands and eyes of Africa.
My guest today is Dr. Lorraine Pfavayi. Pfavayi is the Postdoctoral Research Associate at the University of Edinburgh and a TIBA Postdoctoral Fellow. She holds a PhD in clinical medicine from the University of Oxford, where she investigated fungal allergic diseases in regions co-endemic with parasitic infections. Her current postdoctoral work focuses on developing point-of-care diagnostic tools for schistosomiasis, a neglected tropical disease commonly linked with freshwater snails. She is also involved in the Affected Voices program, which promotes the inclusion of people with lived experience of neglected tropical diseases in health policy and service delivery. Our work is driven by commitment to integrating basic science with global health policy to deliver equitable, context-relevant solutions for vulnerable communities. We begin our chat learning about what motivates our involvement with this area of work.
I often describe my work as sitting at the crossroads between lab science and public health. So I trained as a biochemist for my undergraduate degree, and then I specialized in biotechnology for my master's, both at the University of Zimbabwe. And then I was fascinated by the molecular side of life, how cells work and how molecules interact. But I also knew that I wanted to my work to kind of matter beyond the lab bench. So I then went to the University of Oxford for a PhD in clinical medicine. And during that time, or at least even before, for my internship and during my undergraduate projects and all, I'd had an opportunity to do some fieldwork and research in the neglected tropical disease space. So some of the projects I'd done, I had worked in particularly one of the neglected tropical diseases, which is schistosomiasis, or commonly known as bilharzia. So this is one common, at least, disease in sub-Saharan Africa or even in Zimbabwe. So I think being involved in the fieldwork and seeing what's done and working with the community got me interested in that kind of work, where I have to interact with the community members, but also do the parasitology work where you collect urine and stool samples and basically observe and see parasites in urine and stool samples, which was fascinating for me. But at that point, I didn't know the importance of that work. But then when I started doing my PhD, that's when I got to know why it was important.
You've been drawn to a group of diseases that are classified as neglected. So what has kept you, interested or driven to understand those kind of diseases?
This is a diverse group of 21 disabling, avoidable, and debilitating conditions that affect over 1 billion people worldwide, primarily in impoverished communities in tropical and subtropical regions. Despite their high prevalence, they are classified as neglected because they disproportionately impact the poor, and the regions affected have historically received limited attention and resources compared to other global health priorities. And these diseases thrive in vulnerable and marginalized communities where limited access to essential resources like safe water, sanitation, healthcare exacerbate the burden. So while there have been some global efforts in prevention and control, these have led to maybe a decline in the numbers of individuals that are affected, but we still have some individuals that have the chronic manifestations of these NTDs, which we have like morbidity, the disability, and the disfigurement, that still continue to affect millions of the people, especially in the sub-Saharan Africa. So many of the people that are affected with this, they still live with the lifelong effects, which are not only physically debilitating, but also socially isolating, compromising their mental well-being, economic stability, and social integration. So that's why we're still saying that they are neglected. And even looking at some of the numbers, at the moment, if I still got the numbers correctly, the chronic entities are estimated to account for 19 million disability-adjusted lives, so which are lost annually. However, I think this number actually underestimates the true impact, as it does not consider long-term chronic morbidities and the stigma or the social exclusion or even the psychological toll that accompanies these diseases. And also, it doesn't, the DALIs, basically, they don't primarily account for the patient perspectives or the chronic complications, as well as the shared disability in the presence of comorbidities or the co-current infections in NTD-endemic areas. Because the other thing that we have to think about is how even within the sub-Saharan Africa, we don't only just have NTDs, we also have other infections. So most of the people that are living with these NTDs might actually be living with other conditions as well. So we have the co-infections as well. So now we have to think about the co-current infections in these NTD endemic areas. So the actual impact on health and quality of life may be significantly higher than often reported.
Your work so far on NTDs has explored both the scientific aspect of trying to understand the disease and also, you've also been involved with advocacy programs to just draw more attention to the disease. So can you just walk us through some of the specific contributions you've made so far in the course of your career to the field, to understanding or promoting attention in NTDs?
The group that I'm part of is part of a larger group, which is TIBA, which is Tackling Infections to Benefit Africa, which is a partnership that involves 9 African countries, but we also collaborate with other African countries. So within this partnership, our work works with infectious diseases, not just NTDs, but it's also other infectious diseases, and we do a lot of work even with the NTDs. And the work has done a lot of either in diagnostics or in epidemiology or just basic science, but also do the advocacy work. So as part of the group that I'm in, they have done other work before I was even part of the group. So some of the work that they've done has been impactful, where they contributed to some work where WHO guidelines initially, the under 5s, especially for schistosomiasis, had been excluded from treatment for bilharzia, but now they are now included in treatment. And to kind of give a background why they were not included initially, it was because there was no evidence to, first of all, there was no child-friendly formulation of the drug that is used to treat bilharzia. So the drug is praziquantel. So there were issues about whether the safety and the dosage that's needed to treat the children. But also there was no evidence of whether the children were being infected. So through the studies that the group and other groups were doing, it was shown that actually even children as young as 6 months were being infected with this schistosomiasis. So now, with the work that they did, it was shown that, okay, children also need to be treated. And even now with WHO, okay, they can be treated, but with the work that needed to be done was we cannot do mass drug administration, which is a process where school-going children, you can go and do a program where you treat whether they're negative or positive, you just treat all of them. But then with under 5, so you cannot do that. What you need to do is first diagnose before you treat. So the work that now the group is doing is to say the current standard for diagnosing schistosomiasis is microscopy. So in terms of sensitivity and specificity, microscopy is good in high endemicity area because it's based on parasitology, which is more of egg count. But in low endemicity area, it means you don't have high egg count. So when there is low egg count, parasitology is not very sensitive. So now you have to come up with better diagnostics for low infection areas and stuff. So what happens is that with under fives, they rarely have high infection rates. It's usually lower. So it means that parasitology might not be really sensitive, or microscopy, in microscopy will not be really sensitive in those areas. So now it's coming up with better diagnostics. And also the other thing with under fives, you have to think about, like, for example, with 1 year old, it's not easy to get a urine sample or a stool sample for that age group. So you also have to think about, okay, parasitology, you rely on collecting a urine or stool sample. So there are all those logistics as well when you come in to think about that age group. So thinking like, what would be better diagnostics to use with that age group if you have to continue collecting, if you think about diagnosing before treating. Now the good thing is we now have a child-friendly formulation, but it hasn't been deployed yet. But it's a good thing that we now have that. So hopefully it'll be deployed soon in all the different countries that have schistosomiasis. So that's one of the impactful work that the group has been involved in. The second thing is the advocacy work, where the groups or TIBA has been involved in advocating for patients that are living with the chronic manifestations of different NTDs. Mostly at the moment, it's been lymphatic filariasis, commonly known as elephantiasis, where people now have enlarged or swollen limbs. And then we've got schistosomiasis, where the chronic manifestations can include female or male genital schistosomiasis, leading to infertility or prostate cancer or cognitive impairment in children or liver fibrosis. And then we've got trachoma, which can lead to blindness or visual impairment. And then we had the snake bite envenoming participants as well. So with this advocacy work, what we did, we had workshops where we brought together people living with the chronic manifestations of these conditions. We had researchers, we had the policymakers, we had also the healthcare workers as well, all in one room, where people were sharing their experiences. So the participants or affected voices sharing their experiences, the healthcare workers sharing the experiences where they have to be dealing with the participants as well, and the challenges that they face. And the good thing about this, we're able to hear the different challenges that the participants face, but also the healthcare workers, what they face when they have to be dealing with the accessibility challenges, where they want to help the affected individuals, but then they don't have the equipment, they don't have the diagnostics that are needed. So they'll come there with the participants suffering from the condition, but there's nothing that they can do for them. So with all those challenges, but also having the policymakers in the same room, the policymakers will be like, okay, this is what the participants need. So then when they're now coming up with the policy briefs or changing policies, they know what to include. Because the problem is, at the moment, you've got policymakers making policies without the knowledge of what's needed on the ground. So at least now, if you've got everybody in the room, then you can make informed decisions. So at least that's what we're trying to do with the advocacy, that if you're going to make an intervention and all, make sure you include the voices of the people that need that intervention. Because if you don't do that, the intervention then will not be fit for purpose.
In collaboration with Immunopaedia, we are bringing you something new and fun, quizzes. Immunopaedia is a renowned global platform dedicated to sharing immunology knowledge and resources with students, educators, and researchers around the world. Together, we want to make learning fun and engaging. In this episode, we'll feature just one trivia question. You can find more on our social media platforms, whether it's Facebook, Instagram, X, formerly Twitter, or LinkedIn. We'd love to hear from you and connect with you. Why are neglected tropical diseases described as neglected? Option A, they are rare and occur in very small populations. Option B, they primarily affect populations with limited political and economic power. Option C, they are caused by poorly understood pathogens. Option D, they have no available treatments.
No, while you were speaking, I was just thinking about how that typically with scientists and those who study some of these diseases, infectious or non-infectious diseases, the interaction with the people who are affected by the disease are actually mostly let's go get their samples, let's go to the lab, study these diseases and publish in journals, and just advance our careers. There's helicopter research in which people from maybe the global north come to the global south to do research, and then without involving people in the global south. I think maybe there has to be a terminology for that whole idea of scientists just getting samples and not even involving people the next steps when they've completed their study. So I think it's really beautiful that yourself and the entire TIBA team are able to bring together people with lived experiences and ensure that they are key stakeholders in the development of policies, in maybe the kind of therapies or medications or whatever innovations that would be introduced to help mitigate the challenges they are going through. Perhaps we could just talk about your PhD project a bit. What's the specific aspect of NTDs you looked into for your PhD, and also what you're currently exploring for your postdoc, how it has evolved over the years.
Okay, so kind of to give a brief background, my PhD was on characterizing fungal allergies in Zimbabwe. And like looking at it in an endemic area with parasitic infections. That's where the NTD aspect of it comes in. So sub-Saharan Africa in general is at heightened risk of consequences from already existing infectious diseases and the rapid rising occurrence of non-communicable diseases, including allergies, right? So already an expert predicted that this is expected to peak by the year 2030. So the way forward is for scientific community to shift towards collaborative and multidisciplinary research to aid in understanding disease interactions and their impact on overall health. So with the potential to benefit the health and well-being of millions of people in Africa, my PhD was part of a larger project as well, which had different facets that sought to address the gaps relating to this whole thing of infectious diseases and the co-occurrence of non-communicable diseases. So I was looking specifically at fungal allergies, which most people were like, why fungi? And for me, I was like, well, not many people look at fungi. But if you think about fungi, they're fascinating. First of all, we've got fungi that we consume. We've got fungi that are just spores that we breathe in daily, but nobody's like most people are not even affected by that, right? We've got the poisonous fungi, right? But then, and also fungi are just everywhere, like literally everywhere in all continents and stuff like that. We've got fungi that can survive in different environments, they're thermotolerant and all. So for me, I found them very fascinating. And we've got fungi that can cause invasive diseases. If we think about even like cryptococcal meningitis, if we think about all these other ones, histoplasma and all, and then we've got the fungi that causes allergies. So I was interested in those. And now also thinking about how, looking back when I was doing my master's, I had an opportunity as well to do an internship at a specialist clinic, which saw a lot of people that would come in with allergies or autoimmune diseases. And from there, looking at the data, there were a lot of people that were coming in with fungal allergies, but we're not understanding what's happening and what's the surge that's happening with the increase in these fungal allergies, and trying to understand their immune responses with all the type 3 and the type 1 and trying to figure out what's going on. And so I wanted to incorporate and understand the health systems for disease prevention and management, and overall, like looking at the universal health coverage in Africa. So I wanted to specifically to understand how people of African descent react to region-specific allergens. And thinking about okay, as much as we've got the same fungi throughout, but then because of the difference in the geographic location and the temperatures, what happens with fungi is that sometimes, depending on the temperatures and all, specific proteins, or at least they'll express different proteins and all. So I wanted to see if there'll be differences between Africa and Europe, and would that difference result in different allergens being seen in Africa or not. And the main reason I wanted to see that is because most of our allergen diagnostics have been developed in the West. And because they've been developed in the West, are they fit for purpose for African populations or not? And this comes back to what we're saying, that when it comes to diagnostics or anything, we need context relevant diagnostics. And this was based on other work that other colleagues had done. Like I said, this was part of a larger project where they looked at autoimmune disease, where we're looking at the reference standards that they were being used for African population, where sometimes you find that the reference standards where you're saying, for example, or maybe 20 milligram of this is the standard. But then when you now look at the patients in Africa, 20 milligram might not be what you're seeing. And now you're diagnosing people not in the right way because of the standards that you're using. But that might be because those standards that have been developed are for the Western population and not for the African population. So it's now like, okay, those standards might not work for our population because of genetics, because of the geographical location. So those things need to be taken into consideration. And that's why we need context relevant diagnostics. So that's what I was now looking at for my work. And this is important already looking at high disease burden, for example, in Africa, where we face both infectious diseases and the allergic conditions. So we might have allergies being often underdiagnosed. And already, like I said, I was looking at both in an endemic area, and we've got parasitic infection. So looking at science, we know that with parasitic infection, we have, for example, schistosomiasis would have elevated IgE immune response. But also with allergies, you also have an elevated IgE response. So what would happen then now is that when you have in an area with elevated IgE response and all, could it be parasitic infection or is it IgE? And going back to the hygiene hypothesis, it was always said that, oh, in Africa, because of the environment and the sanitation, allergies are supposed to be low because of the hygiene hypothesis. But what we were seeing is that allergies are rising. Is it because now the environment is becoming clean? Is it because of other treatments and all? So we wanted to understand all those things. And because it could be now with parasitic infections, we're treating the participants and all. Is it because we're treating that we're seeing the rise in allergies or not? So with all those dynamics, I wanted to understand what's happening in the populations. And also with regional differences, most of the allergy diagnostics being based on data from non-African populations, we may miss or misinterpret the reactions to Africa-specific allergens, but also wanted better health outcomes. Understanding local allergen responses allows for more accurate diagnosis and targeted treatment and prevention strategies. And also wanted to strengthen our health systems. Tailoring allergy care to African contexts can help health systems handle the complex challenge of multiple coexisting diseases. So all those things, I wanted to understand them from our African perspective. And I think it was just developing, say, okay, other than just looking at fungal allergies, I wanted to look at with the endemicity of the parasitic infections because we know they coexist. So looking at them together can give us a better picture. And like I said, it was part of a bigger project. So having different aspects coming together and putting all the results could help. But the major challenge to realization of a more holistic impact from our work is to find an adequate financial and human resources to form a multi-site consortium to conduct larger and longer-term trials to establish the applicability based on the nature and the uniqueness of the health delivery systems. So mine was just part of a smaller thing. So even like that work is still going, but it will be the bits and pieces of, oh, we've done this, we've done this. But the challenge is that we are funding, but it would be quite nice to kind of have the long-term trials and have continuity of all these studies so you can have a bigger picture to see what's going on really. But yeah, that's what I was doing with my fungal work. But it was also during COVID-19. So I had to pivot it in another direction as well because I wasn't able to continue with the field work. So part of it, I ended up just using a literature review that was there, where now instead of just the allergy work, I looked at fungal diseases in general. We now wanted to see what's the burden of fungal diseases in Zimbabwe. So with this one now, it wasn't just allergies, but I looked at invasive fungal diseases, just the general ones as well. And what we found was that the burden of fungal disease in Zimbabwe, based on the data we had, was high. But there were limitations with the data because some of the data was a bit outdated. So we show that we need to update the data. We need to also follow up to see what's happening. And also we need to have a high clinical substitution index, because we realized that because some of these diseases are a bit similar to like either TB or some of the people like maybe that might have cryptococcal meningitis might also be infected with HIV and all. So they might not be suspected to have some of the fungal infections. So these fungal infections might not go undiagnosed as well. So those are some of the challenges we're realizing during my study, and like we need to do better as well. So those are some of the challenges, but definitely we do have high burden of fungal diseases, and there is a low suspicion index at the moment with that. Yeah.
Yeah. So yeah, thanks a lot for sharing and providing so much detail about the scope and potential impact of the work. Your ongoing postdoctoral research is also tightly linked to the whole idea of developing contextual platforms or frameworks for understanding entities in Africa. So can you just take us through what kind of project you're looking into for it?
Okay. Yeah. So yeah, initially that was supposed to be the whole postdoc, but obviously things don't always go according to plan,
Mm,
as you might know in academia. So last year I ended up getting an early career research grant. So the
mm,
grant I got was for a pediatric schistosomiasis project, a 1-year one. So now with this pediatric schistosomiasis project, what it was more basically similar to what we're doing before. But what I
mm,
needed now was like, okay, since now under fives can be treated for schistosomiasis, what we needed to do was to basically to determine the feasibility of integrating treatment in early child development centers.
mm,
And the reason why I wanted to do that was like, remember, as I mentioned earlier on, that now as much as WHO has say that for under fives to be treatment, it has to be first diagnosed before treatment. So now I wanted to see, okay, what would be the best strategy to access these under fives? Because for school going children, we can do mass drug administration where you just go to schools and you treat all the children, regardless whether they're positive or negative. But then with under fives, you have to first diagnose and then you treat. So you're just treating the ones that are positive. So now we need to figure out what would be the best strategy. Do you access them at early child development centers? Do you do it at the clinics during the prenatal stages, or what? So what would be the best way? So that was the project I wanted to find out. Would it be best to do it at the early child development centers where they're going at the nurseries or whatsoever? So that was the project I wanted to do, and the impact and the feasibility of doing that. So that was the initial project that I was doing. And while I was doing that project, we also wanted to also try and develop a diagnostic tool, like we mentioned, where we're doing the whole diagnose and test first. And the main reason why we wanted to do that was, like we already mentioned, that with the microscopy, as much as is the gold standard in low infection intensity or in low result setting, it's not the ideal one. And also in terms of logistics of collecting urine samples in 1-year or 2-year-olds is not easy. And with the multiplex one that initially I wanted to do with the postdoc, we have to start somewhere. So the easiest way is to start with one disease. And if it works, then you can go and
scale up
and doing stuff. So exactly. So like rather we start with the schistosomiasis because that's the one disease that we have done a lot of work with. And then we can move up to include the other diseases that we're working with. So with the initial project, the one that we did for the Praziquantel feasibility. It's just ended in July. So that's why we couldn't meet up because I was in the field and doing that. Went well. So now we're just having to write up results because it involved a lot of field work and basically trying to see if it's feasible. It is feasible, but there are a lot of things to consider as well. And also doing some capacity building. And the capacity building that we're doing is most of the work we do it in rural areas and we're helped by village healthcare workers. And with the village healthcare workers, what we do is they're the first point of contact with our community. So as much as we do parasitology, we also do urinary dipsticks, which are the first ones that you can just take in the urine, and they can tell you like other aspects of what's there in the urine. For example, if there's blood in the urine and all, which would be the easiest way to tell if maybe the child has schistosomiasis or not. And from there, you can do other tests as well for schistosomiasis and all. So we're training the healthcare workers or village healthcare workers with that. And also, some of our colleagues developed another diagnostic algorithm. So we're training village health workers to use that diagnostic algorithm to tease out if the child is suspected to have bilharzia or not. So those are some of the things that we're doing in the field. And then also basically comparing those results from those algorithms and the urinary district to the gold standards to see if at least they match up with the results that we're observing. So that was the one aspect of it. And then with the diagnostic test as well, unfortunately, I can't get into much detail with it because there's potential that if it works out, it'll be patented. So I won't delve much into it. It's going to be a serology-based test.
Okay.
Because it's what WHO wants. And the two main groups targeted with this will be the under fives, as we have mentioned, the main reason why, especially if you're going to meet the 2030 goals of basically eliminating schistosomiasis, but also the other group of as well that's targeted with this, it's going to be for verification of elimination as well. So what we're doing is that, so this is like achieving the 2030 targets of schistosomiasis. So basically with this project that we've been doing is it's going to be developing a prototype of a point of care test. And the main reason why it's going to be a point of care test is the communities affected, like we mentioned, they're mostly the marginalized, they're in the rural areas. We want a test that's user-friendly, that's affordable, right? And that's sensitive, that's specific. And so we don't want anything that will be using electricity because we already know that most of these areas that have electricity have got issues like that. We don't want anything that will need expertise because so we've got those issues of shortage of trained personnel in the areas and all. But also want something that's able to give us results within a short period of time. And also we don't want something that has cold chain situation or because also transporting and stuff like that. So those are all the things we're considering when we're developing this prototype. No. So at the moment, there's been a lot of troubleshooting and a lot of tests and stuff like that. Promising results, but also hiccups here and there. And we'll see how the final stages of the bid. So we have an industry partner that we're collaborating with and in consultation with the development of this. So I think what I've learned with this is that it's not easy developing a test.
Yeah.
And a lot of things to consider and all. But I think one thing that I can say is that the work is just based on a lot of initially some of the tests that have been developed has been based on crude parasite antigens. Ours is not based on that. And I'm sorry, I'm trying to figure out what I can say and what I can't say anymore.
Okay.
Yeah. So and it will be detecting parasite specific antibodies. Exactly. So and yeah, and also it's going to be based for detecting both the Schistosoma mannsoni and Schistosoma mitobium, which I think I should have mentioned earlier on that in Zimbabwe, at least the work that we're looking at, there are two types of species of schistosomiasis, Mansoni and hematobium. Mansoni is the intestinal schistosomiasis, and hematobium is the urinary schistosomiasis. So what we're trying to do with our test is to try and make sure that we target both species of the
pathogen.
Of the pathogen. At least that's what we're trying to do, and to try and see if we're able to facilitate early treatment. And also from what we're looking at with the target product profile is to have high sensitivity and specificity. So we have a target profile that we've been looking at that has been developed as well by the WHO team. And from this, we are trying to see which would be the best way to go forward, especially thinking about how most people in the areas have been exposed to, schistosomiasis. So coming up with the best negative controls and negative, so both positive and negative controls. Positive is easy, negative is not. So those are some things we've been thinking about, like, okay, the best ways of doing it and all, but I think I'll leave it there before I say things that I'm not supposed to say.
Okay. Thanks a lot for sharing. Thanks a lot. I think it's really an amazing project, and wishing you and the team all the best with executing it and bringing it to life. Can you just share some of your findings from the other project where you had to, train community health workers for the diagnosis or identification of the disease in infants who are under 5?
Okay. So yeah, I think first of all, from the first field work, prevalence of infection was around 40%, which was quite high, considering that with this area we have been going back and forth, and you'd expect that, okay, yes, the prevalence would be going down. Schistosomiasis, as much as you treat, as long as behavioral changes do not change, or if they continue to go to the same sources of water, reinfection is possible. So it comes back to say, okay, right, this is what we're seeing. What needs to happen? If with schistosomiasis is one of those that if they are still exposed to the same water bodies, then they are still going to be reinfected if you treat them. So there need to be changes with that. But then sometimes it's like, okay, if they're the only water bodies that they have, then what can you do? It's best to make the water body safe for them, because there's nothing else that they can do if they depend on that. So some of those things that now you have to think about, like, okay, how can then you make the water body safe for them? So those are some of the things that we ended up doing, like, okay, it's best to have the conversation with the people to say, okay, what can you do? Having what, like boreholes, building pit latrines or toilets for them or whatever, or even sometimes it's not about doing things for them, but it's having conversations with them, like, okay, you need toilets. There's a community contribute or whatsoever to build a borehole or build a toilet or whatever. Because sometimes it's other things that if you to have conversations with them and they do it for themselves, there's a sense of ownership for them,
True.
So I think there's always that thing, like realizing that it's best, because sometimes there are all these things, like maybe you've got donors coming in doing things for people, they might not even they have that sense of ownership because somebody's done it for them. So but at least if even helping, but then them doing the other bulk of work for themselves and all, there's that sense of ownership. So it's kind of having those conversations and also understanding where they're coming from and all. So even like having some questionnaires where you're understanding why maybe they're not changing certain way of doing things can also help to figure out how you can improve that. So those are some of the things that we also did. But also we also did treatment and all, finding out like the compliance rates, and also found that there was actually like 100% compliance. And also trying to figure out, like, because now we know that a child-friendly formulation of the praziquantel is now available, but it's not yet deployed. But it was also understanding that now with the child-friendly formulation, it's not bitter like the current praziquantel that we have.
I
So
see.
also,
Okay.
and like, okay, as a parent, are they like, when it comes to treatment, like maybe someone will be like, I don't want to give my child a bitter tablet, or I prefer giving my child a syrup or whatever and all sort of thing. But then you realize that the parent will be like, you know what? Yes, a syrup is better because my child can swallow it, better or whatever. But most were like, I don't mind.
Mm,
Whichever tablet, as long my child gets better, that's
mm.
all that matters. So whatever drug is there, as long as my child gets better, that's all that matters to me. So those are some of the things that we're realizing. And also some of them were like, these programs are good, but we want them to be extended to us also. Even the parents wanted the programs, those are
Adults.
focusing to under five, but they want them to be included, especially now where female genital schistosomiasis is quite common.
Mm,
And female genital schistosomiasis, it's now a big problem because it's also a neglected manifestation of schistosoma hematobium infection, and it affects a lot of women in sub-Saharan Africa. So it's characterized by lesions in the genital tract, leading to symptoms like pain, infertility, and increased risk of HIV transmission.
mm.
So, despite its prevalence, FGS remains underdiagnosed and underreported due to limited awareness and diagnostic capabilities. So now you can imagine with FGS like that, infertility is a huge problem where now there's stigma associated with that, or even like I remember in one of our advocacy work where a woman like not having kids is it's a big thing where they're not included in some conversations, or if they try and raise a point, nobody listens to them because they don't have a child or children. So they feel isolated, there's stigma associated with that. So now they also want to be included. And, there's also that need for awareness and also ongoing efforts like to just basically integrate it into services for women's sexual and reproductive services. So there are all those things that we also need to include us, and stuff like that, because they're also infected, because sometimes they're the ones who are going with the children to the river. They are also the ones doing laundry in these infected water bodies and all. So they'll also bring up those aspects. And that was coming up in the conversations we're having, with the treatment. And then in terms of the capacity building, the village workers were really willing to learn. And now, even when we went out for the follow-up, they knew what they were doing, which is good. So it means like now, even going forward, they can be able to do the basic stuff of, the first point of care of just testing your urine. And if the child is suspected to have schistosomiasis from the community, then they can be referred to go to the clinic, because most of the clinics are far from where the community stays. So they have to go, miles and miles to reach a clinic.
Mm.
So if we're able to then say, okay, the first point of the test is close to them, where the village health worker who stays within the community is able to just test the urine first. And if it's suspected to be schisto, then say, okay, now you need to go to the clinic for verification. It makes life easy because at least
True.
they've done this bit. Whereas every time it's like, oh, maybe this, and then having to go and say like, oh, no, it's not. They've gone miles and they don't even have the money. It's a lot. So at least if we can bring it closer to home, it makes life easy. So those are some of the things that we're coming up with. Yeah.
Yeah, you guys are looking at multiple contexts. It's very impressive that the perspectives of the individuals who are affected by these diseases are providing the building blocks for the innovations or products the team is developing to help them deal with the condition. So yeah, well done again. What factors would you think have contributed to your journey and evolution as a scientist?
Um, well, I think that's a good question, but I would say I've been fortunate enough to have um supportive supervisors and mentors along the way, and I honestly don't think I'll be here without them. So even think about the whole journey from undergraduate to where I am, all the research bits that I've done, I had help throughout. So I would say basically, yeah, supports throughout and not giving up. And I think keep showing up most of the time. It wasn't easy, if I must say, but I think that support throughout really helped.
Mm.
And there's sometimes when I didn't believe in myself, but having people that did believe in me helped. Yeah, I think that would be the short answer. Otherwise, we'll be here the whole day if I have to go through it all. Yeah.
Okay. What one or two challenges can you share that you've had to surmount in the course of your journey, or that you're still trying to surmount at the moment?
The greatest one I would say is imposter syndrome.
Oh, I see. Okay.
Oh, yeah. That's the greatest one I can think of right now. I think the persistent feeling that I didn't quite belong in the rooms that I would have said I would have worked out to enter. And sometimes like it made me second guess my ideas and hesitant to speak up. But I think what I've learned over time is that these doubts were not proof of inadequacy, but signs that I was stretching into new territory.
Mm.
Yeah, because I think like, every time it was like, okay, now I'm finishing undergrad, now I having to apply for masters, and oh, I'm not good enough. But it's like, no, I haven't been to that level. It's a new territory. I have to learn. I'm not going to be good all the time. So I think by seeking mentorship, leaning on collaboration, and that's very important. Collaboration is very important. And sometimes daring to take initiative, you know, even when uncertain, and I think it was like learning to replace that self-doubt with a bit of self-trust. And I think with the self-trust, it's not thinking about being proud, no, but just being, like, okay, you know what, I might not be that the best in everything, but I know I can try and do the best I can. And I'm still learning to overcome it, but each step forward reminds me that confidence grows not from knowing everything, but from being willing to learn, to contribute, and to keep showing up.
Many thanks to our guest, you, our listener, and everyone behind the scenes who made this episode possible, particularly team members Cedric and Ciro. If you enjoyed this episode, be sure to subscribe and leave a review on your preferred streaming platform. Also, feel free to continue the conversation with us on social media. Tag our handles at ImmunoAfrica_ or the Immunology in Africa podcast. Support our efforts to amplify African stories of immunology by nominating a guest or buying us coffee. Visit the link in the description or send us an email, immuno.africa@gmail.com. See you on the next episode.